Very good evening to all dear family and audience of CCI. We are together today on another Thursday for the CCI webinar. And today's webinar is on the topic of preoperative pulmonary fitness for surgery. Friends, we all know that surgical fitness, pulmonary fitness for surgeries is a very, very common asked for reference in our practice. And I personally really found this topic very interesting. I'm Dr. Keerat, consultant pulmonologist and head critical care department at Bahara Super Specialty Hospital, Kharar, Mohali from Punjab. And we have the most extraordinary set of panelists today with us. It is my proud privilege to welcome Dr. Rakesh Chawla, sir. Sir is a father figure for all of us. Sir is currently the chairman and senior consultant of pulmonary sleep medicine and especially in IEP, sir is very, very well known. Sir is the chairman of pulmonary department at Saroj Hospital, New Delhi. And I think sir has such a elaborate list of accolades to his credit that everyone knows him, but I would cut it short and just welcome, sir. Sir, it's a proud, proud honor to have you on board. Thank you so much for being here with us. Next, I would like to welcome Dr. Radha Munja, ma'am. Ma'am, we are very happy to have you with us. I am personally always inspired by ma'am's proactive work in pulmonology. Ma'am is the professor and head at IGMC Medical College at Nagpur, Maharashtra. And ma'am is known for her work in asthma and obstructive airway diseases and also for tobacco cessation. Thank you for being here with us today, ma'am. Next, I would like to welcome Dr. Darshan Bajaj. Sir is here with us. Sir is from Lucknow, from King George Medical College. And sir is a senior consultant. And sir has about 45 papers to his credit. And we are very happy to have sir on board with us. Welcome, sir, Dr. Darshan Bajaj.
Dr. Keerat, thank you.
And next, I would like to welcome Dr. Manjunath Bale. Dr. Manjunath is the surgeon on board today with us. Sir is a thoracic surgeon at Apollo City, Hyderabad. He did his MS and MCH from AIIMS, Delhi, and also a fellowship from Shanghai Pulmonary Hospital. Welcome, Dr. Manjunath. Finally, I would like to invite my dear friend and panelist today, Dr. Himani. She's a thoracic anesthetist who did her fellowship from Sri Gangaram Hospital, New Delhi, and her post-graduation from Sri Guru Ramdas Institute of Medical Sciences, Amritsar. Welcome, Dr. Himani. Dr. Himani is attending consultant at Medanta. Welcome, Himani.
Yeah.
Over to Dr. Rakesh, sir, our moderator and staff for the day.
So, welcome everybody to today's CCI webinar, Pre-Operative Pulmonary Fitness for Surgery. Looks very simple. The moment you start preparing for the webinar, you know
make it in a full screen mode.
You know the intricacies, what PAC is involved, what should be done, what cannot be done. It will be very interesting to know. Such a big congregation of anesthetists in the country, the Indian Association of Anesthesiologists does not have the guidelines for pre-operative checkup. Can you believe that? So they are all following American Society of Anesthesiologists or NICE guidelines for pre-anesthetic checkup. This was a new thing to me, and I'm sure to all CCI listeners, it will be mind-boggling that such a huge society of anesthesiologists in the country have not been able to frame the guidelines for pre-anesthetic checkup. I'm going to have you a 1 minute of introduction before Himani chips in. Anesthesia from grief is without anesthetic sensation. The components of anesthesia when the patient is anesthetized, unconsciousness, loss of memory, lack of pain, immobility, attenuation of autonomic responses to noxious stimulations, is defined as a process of clinical assessment which precedes the delivery of anesthesia. For surgery, it consists of consideration of information, multiple sources that may include patient's interview, medical records, physical examination, and findings from medical tests and evaluations. Difficult intubation, an area where the pulmonologist chipped in by either the patients who are in the RTA or by the plastic surgeon or by the surgeon himself when he is feeling difficult intubation. These are the causes of difficult intubation. ASA guidelines are very, very important. 90% of the times when you are in ASA 1 and ASA 2, there are guidelines which are mind-boggling that basic workup is not required for ASA 1 and ASA 2. Very controversial talks as per our Indian situations and our Indian practice. As our webinar will unfold, as the discussion will unfold, I am sure you are going to learn a lot from this webinar. Then these are the classifications of class 3, 4, 5, and 6. And I'm sure Himani is going to discuss all this. Now, when the patient is referred to anesthetist for pulmonary fitness, for pulmonary surgery by a pulmonologist or by a thoracic surgeon or anesthetist refers to the pulmonologist. What are the expectations? Like this case of massive hemoptysis, who came to us, he had a dengue with platelet count of 12,000 rupees. He was discharged after a week, came back with massive hemoptysis. CT scan had a necrotic cavity in pneumonic consolidation with small aneurysms. Bronchial artery embolization failed. 2 times endobronchial placement of glue failed, and patient was referred for thoracic surgery. So when this patient is referred with this necrotic mass with 2 aneurysms which were repeatedly bleeding, lobectomy had to be done. So when you are referring such patients...
Sir, sorry to interrupt you. Sir, your slides are also not moving.
And histopathology came mucormycosis, went for lobectomy, and now I hand over Himani to start how the anesthesia man will walk in and starts doing the workup. I am stopping sharing here.
Hello? Hello? Should I need to play Dr. Himani's video?
Yes.
Okay, fine, sir.
Presentation, I would like to thank all the organizing members of the Chest Council of India for giving me this great opportunity.
You are muted, ma'am. This audience view is muted.
Good evening, one and all. Before starting the presentation, I would like to thank all the organizing members of the Chest Council of India for giving me this great opportunity. So today I'm supposed to speak on preoperative pulmonary assessment for surgery, an anesthetist perspective. So why preoperative pulmonary assessment is important? What are the contributing factors for the pulmonary complications? How to estimate post-operative complication risk, and what is the protocol we follow. So these are the topics we are going to discuss in today's presentation, with a special mention about the thoracic surgery patients. So what we think of preoperative pulmonary assessment is clearly not clearance for surgery. So why the preoperative pulmonary assessment is important? So it is important, one, to stratify the risk factors, and one, to modify the risk factors. So in risk stratification, we identify the risk factors And in risk modification, we address those specific risk factors to modify the patient risk of morbidity. So what are the post-operative pulmonary complications? So post-operative pulmonary abnormality is the one that produces identifiable disease or dysfunction that is clinically significant and adversely affects the clinical course. So it involves atelectasis, infection, including bronchitis and pneumonia, respiratory failure requiring mechanical ventilation for more than 48 hours after the surgery, or an unplanned reintubation after the surgery, hypoxemia requiring oxygen therapy post-operatively, and exacerbation of any underlying lung diseases like COPD or asthma. So they all encompasses post-operative pulmonary complications. So why the risk of pulmonary complications are more after surgery? Because we use intraoperatively inhaled volatile agents and neuromuscular blocking agents during anesthesia. These drugs alter the diaphragmatic and the chest wall function. So they affect the gas exchange, leading to widening of the alveolar arterial oxygen gradient. And secondly, the post-operative pain and diaphragmatic dysfunction that causes the patient to take rapid shallow breaths and unable to take deep breaths. So this further leads to reduced functional residual capacity and ultimately leading to atelectasis. And thirdly, there is reduction in the inspiratory capacity and the expiratory reserve volume, leading to decline in the effectiveness of the cuff, and inability of the patient to clear the pulmonary secretions, leading to retention of secretions, infections, and pneumonias. So now we're going to discuss the contributory risk factors for causing these pulmonary complications. So one is the patient-related factors and the other one is the procedure-related factors. Patient-related factors include the age, like the elderly patients who are more than 60 to 70 years old, the patient-related comorbidities like a known COPD or asthmatic patient, obesity, obstructive sleep apnea, pulmonary hypertension, a patient with a heart failure, a patient who is a chronic smoker, or a patient who had a recent respiratory infection and malnourished. And the procedure-related factors include the site of the surgery. The most common surgeries are the thoracic and the upper abdominal surgeries who have very high risk of developing the post-operative pulmonary complications. The duration of the surgery, the type of anesthesia, that is the general anesthesia versus the regional anesthesia, and the type of the surgery, like it is the emergency surgery or the elective surgery. So how do we estimate these complication risks? So there are various models or scales which are available for that. The most common of that is the ARISCATS index, which we most commonly use. So it has 7 independent predictors for identifying the post-operative pulmonary complication risk. So the number 1 is the age, number 2 is preoperative oxygen saturation, then it is the respiratory infection in the last 1 month, the patient's preoperative anemia or the hemoglobin levels, the site of the surgery, the duration of the surgery, and whether it is an emergency surgery or an elective surgery. And based on the scoring on these factors, the patient is divided into low, intermediate, and high risk for developing the pulmonary complications. So to summarize, the patients who are of advanced age, who have a baseline low oxygen saturation with a history of respiratory infection recently, preoperative anemia, posted for an upper abdominal or thoracic surgery, for a prolonged surgery or an emergency surgery, they are at a very high risk of developing pulmonary complications in the post-operative phase. So what do we actually do? So as an anesthetist, we come in contact with the patient in the pre-anesthesia checkup time in the OPD. So during that time, we take a detailed history of the patient, covering all the risk factors which I just mentioned, and of detailed physical examination accordingly. So we identify the significant risk factors from the history, and according to those risk factors, we get an appropriate evaluation done in form of imaging or PFTs or ABGs or exercise testing. And if needed, we send it and we discuss with our respiratory colleagues for the further assessment and optimization before the surgical procedure. So we come across a lot of patients who have asthma or COPD or OSA All these patients, they come to us in the pre-op, we take their history. If we find the patients are having mild disease or controlled symptoms, then we usually go forward with the surgery. But if the patient is having problems, like they are having an acute exacerbation, or there is a recent infection we are suspecting, or they're developing some kind of congestive heart failure because of their lung conditions, or like in an OSA patient who is in the need of optimization in the form of CPAP or BiPAP or some kind of therapy, then we send these patients to our respiratory colleagues for further assessment and optimization for the surgery. And if possible, we kind of postpone the surgery if it is an elective procedure. And here are some of the pre-operative interventions, what we can do at our level to reduce the chances of developing post-op complications. The most important is the smoking cessation. The best results are seen if it is stopped at least more than 8 weeks prior to the surgery. And the patient with exacerbation of COPD or asthma, for that we can increase their bronchodilators, we can start on with steroids and delay their surgery and start with antibiotics for the infection. For stable cases, we can continue with the treatment and start up with the physiotherapy and a rehabilitation, which is very, very important for these patients to prevent any post-operative complications. Similarly, in obese patients, we can start with their weight losing program and physiotherapy. And if they are in need of CPAP or BiPAP for OSA component, we can initiate with that. And in malnourished patient, we can go for the oral nutrition programs. So that was a discussion about in general for the, in general surgeries. Now I'm going to discuss about thoracic surgery, because these are the patient population who are, at risk of developing the pulmonary complications. They are at a very high risk of developing the pulmonary complications. So in thoracic patients who are undergoing for a lung resection surgery, maybe in a form of lobectomy or pneumonectomy or a segmentectomy or a wedge resection, so they are going to be assessed basically in 3 steps. One is the lung mechanical function, one is the pulmonary parenchymal function, and then the most important of all, the cardiopulmonary interaction. Okay, and the last, which is used in the selective cases, is the regional lung function assessment tests. Now, talking about the lung mechanical function, here we study about the mechanics of the lung. So FEV1 is considered as the most important and the independent predictor of the respiratory morbidity. So if preoperative FEV1 is less than 30% of the predictive, there is very high chances of morbidity and mortality in the postoperative period. And if it is more than 60% of predicted, then the chances of complications and morbidity is comparatively less. So if FEV1 is more than 80% of predicted or more than 2 liters, so this patient is suitable for any kind of resection surgery, including a pneumonectomy, without any further evaluation. And if it is more than 1.5 liter, then the patient is suitable for a lobectomy without any further evaluation. And another important, very important predictor in the lung mechanics parameter is the predictive post-operative FEV1, where we can calculate the post-operative FEV1 by using the pre-operative FEV1 using this formula. And by this, we can calculate the predictive FEV1, post-operative FEV1. So if the predictive post-operative FEV1 is coming out to be more than 40%, then this patient can tolerate the resection surgery, and that patient can be extubated on table immediately after the surgery without, in much complications. If the predictive post-operative FEV1 comes out to be between 30 to 40%, then we can, patient has slightly higher risk of developing the post-operative complications, but still we can consider extubation of these patients if their exercise tolerance and the parenchymal function is within the normal limits. And if it is less than 30%, then there are very high chances of developing the post-operative complications. So in these patients, generally the staged weaning from mechanical ventilation is preferred. But the extubation can be considered only if there is, good exercise tolerance and parenchymal function, and there is a thoracic epidural analgesia for pain management. Now coming on to the pulmonary parenchymal functions. So there are two parameters to decide that. One is the diffusion capacity for the carbon monoxide, and one is the arterial blood gas analysis. So if the predictive post-operative DLCO is more than 40%, then the patient can very well tolerate the surgery. And for ABG, the cutoff values are a preoperative PaO2 of 60 and PaCO2 of 45. And the third leg of this assessment is the cardiopulmonary interaction, which is the most important of these three. Here it is to stress the stress is to the whole cardiopulmonary and the systemic oxygen delivery systems, and it estimates the physiological reserves that may be available after the surgery. VO2, that is the maximum oxygen consumption, is the parameter which is used here and calculated here, which is one of the most important factors. So various tests which we can use is the stair climbing test, the 6-minute walk test, and fall in oximetry test. These are the basic routine clinical tests. And one is the more extensive is the cardiopulmonary exercise testing, which is the gold standard with the expired gas analysis. Now, the stair climbing test, it can be, the first line functional screening test to select those patients that can safely go for surgery. So it is documented as the number of flights a patient can climb at his own pace. If more than 5 flights of stair he can climb, then his VO2 is more than 20. And if 2 flights, the VO2 is around 12 ml per kg per minute. A VO2 of more than 20 is suggestive that patient can tolerate the surgery very well. And VO2 of less than 10 means it is kind of a contraindication for surgery. Next is the 6-minute test. That is the distance the patient can travel in a 6 minute on his own pace. So that can be, indirectly used to calculate the VO2. And the third test is fall in the oxygen saturation. More than 4% fall during the exercise, those patients are at increased risk of developing pulmonary complications. Then lastly is the CPET. That is the sophisticated physiological testing technique that provides an objective evaluation of functional capacity of both the lungs and heart. Result of such testing is the maximal oxygen consumption, that is VO2, which I've already discussed. But because it is very extensive and expensive test, so routinely it is not practiced. This I've already discussed. So this is the concise form of 3-legged stool, which I discussed. One is the respiratory mechanics, one is the lung parenchymal function, and the other one is the cardiopulmonary reserve. So for all the thoracic patients, in starting, we assess for their exercise tolerance by using that stair climbing test and walk test. The simple spirometry is done so that we can get a value of FEV1 and we can estimate predictive post-operative FEV1, discuss about the post-operative analgesia and smoking cessation. So the patient whose predictive post-operative FEV1 comes out to be less than 40%, then we need to go for full pulmonary function testing, including the DLCO, VQ scanning if needed, and exercising testing, that is CPET. Now, VQ scanning, it is mainly indicated for patients, who are posted for pneumonectomy or who are posted for a redo surgery, like already a lobectomy is done and again posted for a lung resection surgery, to have an idea about the functionality of the part of the lung which are removing right now, whether that part of the lung is contributing to the ventilation perfusion or not. And the other very important part of the pre-anesthetic examination is the airway examinations. So in addition to the routine airway examination, which we do in all the patients, so in thoracic patients, we generally need to put a double lumen tube, which is different from a single lumen tube. So for that, we need to assess whether it is going to be difficult to put in that tube or not. So for that, we can use chest X-ray or the CT scans, which are already there with us in the pre-operative period, to assess the, the size of the tube we have to put during the surgery and whether it will be easily put or not put. Like we can use the diameter of the trachea or the left mid bronchus as a guide to decide the size of the tube. So this is also part of the evaluation in the preoperative phase. Like the patients for tracheal resection and anastomosis with tracheal stenosis or tracheal tumors come to us for the surgery. There also these CTs and your X-rays, they help us to locate the narrowest point, the width of the trachea and at what level the stenosis is present. So we can plan our anesthesia accordingly. And in addition to that, the preoperative workup done by the pulmonology people in the form of fiber optic, that also gives us a guide to decide the size of the tube we need to put. Similarly, in the patients coming for huge mediastinal tumors, causing the airway compression, we get a very good idea from these imagings. So to conclude, the anesthetic preoperative evaluation of a patient prior to surgery can be very challenging, but it is frequently fruitful. Advances in anesthetic management, non-invasive surgical techniques, and intensive care have gradually but progressively lowered the threshold for declaring patients to surgical candidates. Thank you.
Please be ready. Should I give the countdown? 5, 4, 3, 2, 1. You are live again.
Very nice, Dr. Himani. You have done a good justification to your talk. But whenever a pulmonologist is called for a PAC, he will come and have a detailed history of the patient, and we need a pre-operative X-ray chest. An indication of chest radiographs are new or unexplained symptoms or signs when there is a history of underlying lung disease and no recent chest radiograph is there, and when the thoracic surgery has been planned. Then the pulmonologist look for a spirometry. We are going to have a good discussion on whether the routine lab results are required or not for the PAC. We need a routine X-ray chest or no. We need a routine spirometry or no. So what is the PFT? It helps us to diagnose and differentiate restrictive and obstructive lung diseases. It explains the cause of symptoms in patients who are diseased and clinically normal, like you are able to find the small airway disease, or you are able to find the occupational injuries. And of course, you are going to use it for PAC, as you have told the importance of FEV1. If it is more than 80%, you are scot-free for any kind of a surgery or any kind of anesthesia. So various contraindications are there when the patient is uncooperative. He has got an infectious disease, especially during the COVID times. The pulmonary function tests were not done till you have the negative room where there is a negative ventilation and you are taking all precautions. Otherwise, this was the time we are going to discuss with you how you were managing during COVID time your patients without this spirometry. Patient has hemoptysis, patient has myocardial infarction, or recent and abdominal thoracic surgeries, or patient has a recent eye surgery. These are the various spirograms for your experience to see. This is what is acceptable with the volume time graph, and rest you can see when cough happens, or there are variable efforts or glottic closure, you are able to see these different graphs. The PFT, a good spirometry, is that you are able to reproduce it at least in 2 or 3 readings, that they are matching each other. The best 2 blows within 5% or 200 ml of each other, we pass it as a good spirogram. You prepare, you give instructions how the PFT is done. Since topic is a PAC, I'm not going in details with the things. You have 4 volumes and 4 capacities which pulmonary function will measure. So the FEV1, and when the patient normal, people can exhale more than 75 to 80%. Their FVC in first second, the percentage can be utilized to characterize the lung diseases. Normal is more than 75%, and very severe is less than 35%. As you have said, the FEV1 less than 30%, the patient is going to get into the post-operative complications. So what is the forced expiratory flow? Is during the middle half of the FVC, and it depends heavily on FVC and reflects the status of small airway disease. Then you have the FVC percentage.
Sorry to interrupt you, sir. Your slides are not moving. Sir, slides are not moving.
Slides are not moving?
No, sir. And no, it's not in a full screen mode also, sir.
No, it is in a full screen mode.
No, sir.
I again will share.
Yes, sir. Please do it.
Okay. I'm sharing again. All right now? Moving now?
No, sir, not yet. Sir, you need to unshare it and just share it again.
Okay,
Press
I stop.
escape.
Okay, I share screen now.
Yes, sir. Yes, sir.
Now it is in a full screen mode. Moving now?
No, sir, not yet, sir. So just
Why?
press escape. Press escape.
Okay.
Escape
Okay.
and unshare. Okay.
The
Sir,
slide is
unshare.
Now full screen mode. Moving now?
Slides are moving, sir, but it's not in a full screen mode.
No, this is now, it is not in a full screen mode. Now this, you tell me now, in this mode, the slides are moving or no?
Yes, they are moving.
Now they are moving?
Yes, sir, they are moving, definitely.
Okay. So I will continue with this. I continue like this.
Okay, sir, but it's not in a full screen mode.
Okay, now I am switching on to full screen mode. Now moving?
No, sir, not yet. Slides are moving, but it's not in a full screen mode.
Okay, they are moving.
Yes, sir, they are moving, but it's not in a full screen mode, sir.
Never mind. Now, in my computer, it is in a full screen mode.
Okay, sir, just unshare and share it again, no, please, sir.
I stop share.
Yes, sir.
I share again.
Yes, sir. Yes, sir.
Okay, I shared. Share. Now, is okay?
So try clicking the slideshow on the top.
Okay.
Just try that.
Where is the slideshow?
Next to animation and review.
Slideshow.
On the top, sir.
Pause, share, new share.
नहीं सर, home insert design animation के बाजू में slideshow.
Yes, yes. Up. Take the cursor up a bit. On the left.
Left.
On the other. Yes, yes. Up.
Yes. Go up. Slideshow.
Here?
Animation के बाजू में.
Yeah, yes, this, sir.
That's
Click,
it.
from the current slide.
Okay. Now slideshow now.
Sir, on the left, go to from current slide instead of from beginning.
Okay.
आप left जाइए sir. Left जाइए. और left जाइए.
Click this.
हाँ, बस that is it.
Now all right?
Yes.
Just,
Click it.
Just click it. It should work.
Okay.
Click it again if it doesn't.
Working now?
Okay, sir. Go on to from beginning. Just go to from beginning, sir. Next to it. Next to it.
आप left जाइए. Left icon. हाँ, yes, that's it.
Click. You need to click it, sir.
Okay.
Click नहीं हो रहा है ये actually आप जहाँ पे cursor लेके गए हो.
आपका mouse या cursor नहीं काम कर रहा है.
It's moving.
Double click करो sir उसको.
Okay. Double click किया तो दो बारी move हो गया वो.
नहीं हुआ तो F नहीं सर ये click करके हुआ नहीं. आप function दबा के F5 दबा दो. F5 and function from the keyboard. That should work.
F5 and the function.
Function, yes sir.
Where is the function? F5 is there. Where is the function?
Sir, bottom left.
We can present it like this also.
And sir, just double click on any of the presentation, sir, manually. Just double click on any of the presentation. Manually, just manually do that, sir.
Okay. Now moving.
No, sir. Just double click on the presentation. Yes, sir. Okay, fine, sir. Slides are moving. You can move ahead.
Let me finish. No, the time we will waste.
Yes, sir. You carry on, sir. No issues.
Carry on.
You are able to see the slides, right?
Yes, sir.
Audience
Yes.
is able to see them.
Good enough.
Okay. Okay. We need to have a good preparation for the patient for spirometry. We measure 4 capacities and 4 volumes. What is an FEV1? You have heard the importance of FEV1. If it is more than 80%, your patient is scot-free. There is no chances. So basic test even is able to help doing the thoracic surgery. Then the forced expiratory flow, it helps to reflect the status of the small airways. FEV1 percentage tells you whether patient has got an obstructive disease or he does not have an obstructive disease. If the value is less than 70, we are able to understand it is an obstructive disease. And if it is more than this, the patient does not have an obstructive disease. The maximum voluntary ventilation tells you about the respiratory muscle assessment. Peak expiratory flow rate, it can make the patient himself a doctor to treat himself, especially in an asthmatic. He can see the difference of the flow rate and can increase or decrease the medication. This is how the obstructive pattern looks like. This is how the restrictive pattern looks like. And this is how, when there is a mixed blockage, that patient has got he is a smoker and he is an asthmatic, and you are able to see a mixed pattern. And reversibility has to be more than 12% increase in FEV1 or 200 ml of improvement in FEV1. We are able to diagnose that patient has asthma, or if the patient is a hallmark of asthma is the reversibility. If the patient has a history related to the smoking and things are not reversible, there are no histories related to asthma, you are able to diagnose that obstructive disease as COPD, which has a history of chronic cough, chronic sputum production, recurrent lower respiratory tract infection, and history of risk factors, especially smoking. So this is how, by seeing the graph itself, you can tell the patient has got an obstruction, or it is a normal graph, or the patient has got a restrictive lung disease. Now coming to the DLCO. What is the DLCO? It's a transfer factor. And again, it helps to assess the ability of the lung to transfer gas from inspired air to the bloodstream. So the inhaled CO is used because the oxygen is not preferred, as the uptake is limited by cardiac uptake and total body consumption. There are factors which affect the DLCO measurement. If the patient in spirometry has got an obstructive pattern and DLCO is low in cases of emphysema, and if it is normal, it may be chronic bronchitis. And DLCO with restrictive patterns, probable, if it is low, it is probable ILD or pneumonitis. If it is normal, patient has got the chest wall disorders. And DLCO with normal lung mechanics, if it is low, pulmonary vascular disease, and if it is normal with normal PFT, so it is going as normal. Another common applications of DLCO in detection the mild ILD in high-risk patients, and including those with sarcoidosis, hypersensitivity, pneumonitis, chest irradiation, and cancer chemotherapy, use of drug known to have pulmonary toxicity, a very sensitive test to tell you about the changes in the parenchyma, and you are able to find out very early, especially the cases of ILD and the progression of ILD. This is a test which is very, very important. You have already heard about the 6-minute walk test. The patient can walk and you are able to measure the capacity. They are not specific values, but it is very, very important in exercise testing. Now, when you are evaluating the patient for lung resection, there are 2 broad issues. What is the surgical morbidity and mortality for the patient with significant underlying chronic lung disease? Will post-operative lung function be adequate to support a reasonable quality of life? The post-operative pulmonary complications following pneumonectomy cases are significantly when FEV1 is less than 2 liters or 80% of the predicted normal. For lobectomy, an FEV1 of 1.5 appears to be critical threshold. DLCO has also been identified as a predictor of post-operative complications. All patients for lung resection, you need to measure FEV1 and DLCO and calculate both PPO, predictive post-operative FEV1, and predictive post-operative DLCO, as the formula has already been told, to see how the lungs will remain post-operatively. So both PPO FEV1 and PPO DLCO, if it is more than 60%, And as per ERS, if FEV1 and DLCO is more than 80%, no further tests are recommended and the patient is a low risk, so there are no issues. So this is how you calculate PPO FEV1 and PPO DLCO to see the predictive post-operative values. As Dr. has told about cardiopulmonary exercise testing, it is a sophisticated physiological testing technique, expensive. Measurement is of maximum oxygen consumption of Vo2 max during cardiopulmonary exercise testing. Risk for perioperative complication has been reported to be higher with lower measured Vo2 max. If Vo2 max is more than 20 ml per kg per minute, or 75% of the predicted can safely undergo a planned resection like pneumonectomy. If Vo2 max is between 10 to 15 ml per kg, or 35 to 75% of predicted, and there are increased risk of perioperative death compared with higher values of Vo2 max. So Vo2 max is a very good predictor. Since the test is expensive, the machines are expensive, all institutions does not have CPAT. And role in lung resection is the Vo2 peak. Less than 50% of the predicted is associated with higher morbidity and mortality after lung resection. So Vo2 max more than 20 ml is a low risk, and Vo2 max 10 to 20 ml per kg per minute is a moderate risk, and Vo2 max less than 10 ml per kg per minute or less than 35%, the patient is in high risk. CPAT role in lung transplant is useful in assessment of disease progression before lung transplant, functional capacity, causes of exercise limitations, and rehabilitation. It helps post lung transplant. The stair climbing test, again, it is a cheaper version. You can use it to replace the Vo2. If the patient is able to climb 5 flights of the stair, it predicts Vo2 are more than 20 ml per kg per minute. So this is how the equivalence has been created, and if he is unable to, then it is a high risk case having less than 10 ml per kg per minute. You have a shuttle walk test, again an improvisation of the 6-minute walk test. So in this, the patient has to walk back and forth over distance of 10 meters at progressively faster rate for 12 minutes, and each 10-minute trip is a shuttle. So if shuttles are less than 25, peak Vo2 is less than 10 ml per kg. Again, it will give you a high risk patient or patient is low risk. Very important parameter, ventilator anaerobic threshold. This is how estimates the metabolic acidosis due to the rise in arterial lactate during exercise, expressed as percentage of Vo2 max. Normally 50 to 60% of predicted Vo2 max is a normal anaerobic threshold. I don't think anybody is practicing these parameters before taking the patient for surgery. Another, the body box is a well-established technique of lung functions determination. The rationale is spirometry is the gold standard in lung functions, while body plethysmography allows to determine these and other characters such as airway resistance, intrathoracic gas volume, which spirometry does not give you. These are forced residual capacity, residual volume, and total lung capacity. You get it from body box. So as told you, these are the volumes and these are the capacities. This is the amount of inspiratory reserve volume or the residual volume you are able to measure with the body box. This is how the apparatus looks like. There is a proper procedure to do it with their software to have the interpretations. This is patient with obstructive lung disease will have elevated TLC, FRC, and residual volume. And in restrictive lung disease, the expansion is inadequate and decreased ventilation. Patient will have decreased lung volume, decreased TLC, FRC, and residual volume is reduced. So how you see this in normal subjects, a steep linear loop during tidal breathing without any hysteresis or without any openness is there. It is a curvy linear shape. You are able to see it's a normal when you are doing a body plethysmography test. So these are the various in the normal case, or a subject with increased airway resistance, or subject with chronic airflow obstruction, or patient with obesity with decreased diaphragmatic movements or diaphragmatic paralysis, or patient with upper airway obstruction. As in PAC, Dr. Himani has already enumerated, the patient has to be evaluated with the proper history and examination. The pre-operative pulmonary preparations are very, very important. Smoking cessation at least 8 weeks before taking up of surgery. I do not know how much relevant is true in the practice. Our thoracic surgeon is going to explain, are they able to follow, or they pick up the patient and do the pulmonary rehabilitation and go ahead with the surgeries. So patient has to have the post-operative measures to avoid complications with early mobilization, with prophylactic lung expansion maneuvers, provision of adequate analgesia, or the prophylaxis of thromboembolism. Post-operative pulmonary complications contribute to the perioperative morbidity and mortality. The incidence is 2 to 19% in non-thoracic and 19 to 59% in thoracic patients. Perioperative complications can be aspiration, atelectasis, pneumonia, bronchitis, bronchospasm, hypoxia, acute exacerbation of COPD or respiratory. There are 10 factors predisposing to aspiration: emergency surgery, inadequate anesthesia, abdominal pathology, obesity, neurologic deficits, lithotomy, difficult intubation, reflux, or hiatus hernia. So factors associated with development are already being explained by Dr. Himani. The pharmacological agents which can help in reducing the pulmonary aspiration: histamine 2 receptor antagonists, antacids, proton pump inhibitors, or gastrokinetic agents. Post-operative pulmonary complications can be nosocomial pneumonia, lung atelectasis, respiratory failure, air leaks, pulmonary embolism, exacerbation of underlying chronic lung disease, bronchospasm, and aspiration pneumonitis. Following thoracic and abdominal surgery, the patient will have a restrictive lung disease, maybe in the beginning, but pulmonary rehabilitation will help him to resume to the normal functions. But if it's a lower abdominal surgery or peripheral surgery, the lung functions are never get impaired. Thank you very much. I invite now the thoracic surgeon to please take over. I am stopping sharing.
Sir, should I need to play recorded video?
Correct.
Okay.
Yes. Good evening, everybody. I'm Dr. Manjunath. I'm a thoracic surgeon at Apollo Jubilee Hills. Today, we are going to talk about something very important and a very necessary topic for all the surgeons to understand. More so because we are talking about preoperative pulmonary evaluation and I'm going to give a surgeon's perspective of what exactly a surgeon should look forward in any patient. So why do we have to evaluate? Because one has to understand that the pulmonary complications are more common than cardiac complications following any surgery. So the frequency can be about, say, 5 to 70% of patients can have pulmonary complications. Once the patient has a pulmonary complication, it's going to increase the hospital stay by at least 2 weeks minimum. And then it also increases the perioperative morbidity and mortality. Some surgeries are very notorious for having these pulmonary complications, especially the cardiac and upper abdominal procedures. Emergency laparotomies also have a very high risk of pulmonary complications. Even in the minor procedures, you can see the incidence is about 1 to 2% of patients developing complications. So why do we have to evaluate? So for the first one of the reasons is to identify if there's a dysfunction of the lung. If there is a dysfunction of the lung, explain the patient that the course of the hospitalization and recovery period is maybe prolonged, and you have to also explain the patient that it can negatively impact the outcome, and also expect some complications like atelectasis, infection, bronchospasm, in fact prolonged ventilation also. So that is of why, and we'll see who, because whenever we talk about a patient, we see various factors. One of the most important factors is age of the patient. Age over 60, they require some kind of evaluation by a pulmonologist, preferably. If they have a pre-existing lung disease, definitely one has to see a pulmonologist before a major surgery. If he's a smoker, again, it's better to have an evaluation by a good pulmonologist. If patient has by any chance a document of previous FEV1 of less than 1 liters, then it's better to further evaluate the patient and see whether he's fit enough for the surgery. And these are the 2 other important things which I would want to emphasize more, because I am a thoracic surgeon. For all the non-thoracic surgeons who are listening to this, if the duration of surgery is more than 3 hours, anesthesia is more than 3 hours, then one has to get the pulmonary evaluation done before surgery, especially if it's a head and neck surgery, if it's a upper abdominal surgery, and if the patient is on a prolonged nasogastric tube prior to surgery. All these patients have higher risk of pulmonary complications, so getting them, evaluating and optimizing them is a very important step in this process. See, one of the things we have to understand is it is not just about the evaluation, but it's also about the optimization of the patients. We have many medications which can be given to the patient before the surgery for better outcomes post-op. We can ask them to do incentive spirometry, we ask them to do yoga, we ask them to do deep breathing exercises prior to the surgery, along with all the medications that are given, so that the optimal health is reached before the surgery, the person undergoes a knife. So coming to a topic which we deal with, which I deal with more often, is the assessment of a patient for thoracic surgery. So one of the things is whether we have the diagnosis, we have the indication, then we should see what is the cardiopulmonary reserve. So that is one of the most important things for thoracic surgery, and also risk stratification, and if the tumor is resectable or not resectable. So the first and the most common test which we do is a pulmonary function test. Most of us know what is an FEV1 and FEC. So this is just the grading of what is moderate, what is mild restriction, what is severe restriction, what is normal. So FEV1 and FEC of more than 80% and FEV1 by FEC ratio of more than 70 to 75% are considered normal. Anything less than that, it's mild, moderate and severe based on the percentages. So one of the things which we routinely do is check the response to bronchodilator. So if we say there's a positive response, you have to see first what has been the increase in FEC. If it's more than 10%, we take it as positive. If the FEV1 has increased by more than 15%, or the value of the FEV1 is more than 200 ml after bronchodilation, or if the FE of 22 to 75% is more than 20% increase, we take that as a positive response. Even if there are 2 out of 3, then we take it as a positive response to bronchodilation, and then that means the patient will do well with bronchodilation and he can be taken up for surgery. So this is just an overview of how you classify the risk. Okay, so the FEV1 of more than 60%, no risk, patient can go home, undergo a surgery. The DLCO of more than 60%, again no low risk. Okay, he can undergo a surgery in general. And for thoracic surgery per se, we take various values. Okay, I'll get to that in the later slides. And then if you're talking about pulmonary resection, you talk about post-operative FEV1. Predictive post-operative FEV1. So if it's more than 40%, and if the predictive DLCO is more than 40% and room air saturation is about more than 90%, then it's an average risk. If the FEV1, predictive post-operative FEV1 and DLCO are less than 40%, then it's considered to be high risk. So now how do you calculate the post-operative FEV1? So that is pre-operative FEV1 into how many segments you have minus the segments to be removed. For example, if you are taking out the upper lobe, right upper lobe, you have 3 segments. So 19 minus 3 would be 16. That will be 19 minus 3 will be 16. So you divide those 3 segments and then you calculate the total volume. So that's how it is. So it will be post-operative pre-operative FEV1 into 16 will give you the accurate value of the post-operative FEV1. So after a certain period of time, people have realized that the post-operative FEV1 is the most important, one of the most important factor to predict mortality. If it is less than 40%, the chances of mortality are high. If it's less than 30%, if the mortality rates are even higher, it is also a best predictor of complications. But in some series, they've also found that even with poor lung function, they do well. So if the other problem which happens is if the pre-operative FEV1 is more than 70%, then you cannot predict properly, because even then the mortality is about 5%. So that is one of the problems with having a PPO FEV1. The immediate post-operative estimation of pulmonary function can be misleading, because the patients recover from their surgery and they have small complications. Then actually when the residual FEV1 comes only at about 3 to 6 months. And it generally overestimates in the initial post-operative period. If you do an FEV1 on POD1 after lobectomy, actually FEV1 will be 30% of the lower than the predicted value, because that's because of the pain, the patient's stress due to surgery. So those things are not very well taken. PPO-FE1, 40%, currently distinguished between normal and high risk. Suggested limit, if there is less than 30%, then it is very high risk for a perioperative mortality. So once we do a PFT, now as a standard practice, we also do DLCO. DLCO reflects the functional surface area of the lung. The DLCO is diffusion capacity of the lung for carbon monoxide. So it is an independent factor to predict post-operative mortality and morbidity. The normal range varies about 75 to 120%. So DLCO is a proxy measure for alveolar oxygen exchange. We can't measure the alveolar oxygen exchange, so we measure carbon monoxide diffusion. So we use it as a proxy. See, the early reports say that they are decreased after lung resection, as well as a lower DLCO associated with increased operative mortality after lung resection. So we saw that if the DLCO is less than 30%, then there is a definitely higher mortality. So now what they have come to know is this is a most important independent predictor for post-operative mortality and morbidity. So again, lower pre-op DLCO are also related with poor quality of life and as well as recurrent readmissions. Again, the factor is less than 30%. If there is less than 30%, you definitely have to consider whether you should do the surgery or not do the surgery. In some cases, the DLCO is not helpful, especially in cases of COPD. The value of DLCO becomes questionable. So whether we should do, this is the recommendation of ERS and ESTS combination. They said that it should be recommended to be done in all patients regardless of the spirometric evaluation, and DLCO of less than 30% should be considered as a high risk parameter to do any lung resection. So the next test which comes into this thing is a 6-minute walk test. One of the few important contraindications for this is an unstable angina or the heart or an MI within last few months. You should not do a 6-minute walk test. Resting tachycardia, uncontrolled hypertension, those patients should not undergo a 6-minute walk test. A 6-minute walk test is basically you will ask the patient to walk for 6 minutes, and then you check the amount of distance they cover, what has the saturation been throughout the thing, what has the heart rate been throughout the whole process. Nowadays, they are not, the latest ESTS guideline says that you should not do a 6-minute walk test for preoperative risk stratification. I just put it as this thing. I will tell you the importance also in the coming slides. So now the other thing is you do a shuttle walk test, a walk test based on a 20-meter shuttle run. Okay, so it measures the maximal distance walked by a patient at a pace set by audio signals. So it requires patient to walk at increasing speed ups. Okay, for like ups and down or 10 meter course. Speed of walking is increased every minute by about 0.17 meters per second. Then if the patient is able to cover 25 shuttles, that means his Vo2 Max is about 10 ml per kg per minute. So this is a more reliable one, and if the patient is covering more than 400 meters, it is considered to be a normal one. So the next step is a stair climbing test. Among all the tests, these walking tests, stair climbing test is considered to be the most safest and most reliable. If the patient is able to walk more than 22 meters, that means his Vo2 Max is more than 15 ml per kg per minute. That means he's safe to undergo a surgery. If it is borderline, that is between 12 to 22 meters, that means the Vo2 Max is less than 15. That means he will need a formal cardiopulmonary exercise testing. The cardiopulmonary exercise testing will be well covered by Dr. Chawla. And if it's less than 12 meters, that means his patient is not good and there's a very high mortality because of that. So again, this is an invasive one. We have to do that is called as Vo2 Max. That is the best available index for the assessment of exercise capacity. Vo2 Max is when the plateau of this thing is achieved. When Vo2 peak is when Vo2 at maximum exercise, but not need to plateau. And we are in a lot of cases we use Vo2 Max and Vo2 peak very synonymously. So if more than 84% of predicted normality is there, then the resting Vo2 will be about 3.5. the Vo2 max will be about 30 to 50 ml per kg, and sometimes in case of athletes, the Vo2 max can be very high, like about 80 ml per kg per minute. So that is about exercise testing. I think Dr. Chawla will discuss more about CPET and everything. So the other important test I get it done is a VQ scan. The VQ scan is basically the ventilation perfusion scan, which is more used in pulmonary embolism. But we also use it because we get a fair idea of how much of the lung is actually contributing to the ventilation in a given condition. For example, if a VQ scan, if I am doing a pneumonectomy for a destroyed lung, if I get a VQ scan and if it shows 98% on the right side, 2% on the left side, I would not be bothered about the FEV1. And if the patient is walking, talking and coming to my OPD, I wouldn't bother doing a pneumonectomy without anything, because that means the lung itself is not contributing anything for the ventilation. So that is one of the important aspects of doing a VQ scan, especially in our scenarios, because in case of malignancies, you're removing a lot of normal lung. So in that case, your VQ scan will help us in diagnosing the area of lobectomy or a pneumonectomy, which is contributing. For example, if the upper lobe is contributing to 10% of the total volume of ventilation, and if the FEV1 is 2 liters, that means you're losing only 20%. That means 200 ml, that is about 1.8 liters of post-operative predictive FEV1, which is quite good for any patient. So that is one of the helps of using a VQ scan. So there are other tests called as split lung studies, which is not very useful. Basically, you're trying to see, just like when they do it for kidney, whether how much is the scintigraphy uptake being, especially for pneumonectomy, it can be helpful, because if it's not contributing much to the ventilation, then we can assume that it's not going to affect the post-operative lung function. So you can take out the lung without any much fuss. So correlation between the actual and predicted FEV1 is quite good with split lung function. But only problem is there is no additional benefit of doing this, because now we have quantitative CTs. So once we have a CT done, we know that that part is not attenuated, it is expanding well. Then we take that itself as a example, because that is more easier and more practical to do. The exercise testing, the aim is to see whether there is the whole cardiopulmonary system is ready to take so much of stress. It also gives us an estimate of the physiological reserve available after surgery. And during exercise, there is increase in the ventilation, the oxygen uptake, carbon dioxide and carbon flow, similar to what you see in the post-operative period. So this is the single test. It gives us a physiological response after surgery. So the hypothesis is to unable to perform adequately is like as good as patient undergoing a stress of the surgery. So that's what will give us a fair idea of how is it done. So it is only done in select cases where the patient is not having a good DLCO and not having a good pulmonary function test. So the evidence says that if the exercise testing is 50 to 60%, then it increases the mortality of the surgery. If the Vo2 max is more than 200 to more than 20 ml per kg per minute, it is considered to be safe. If it is less than 40% or 10 ml, then surgery is contraindicated. So this is very important, because once you have a Vo2 max of less than 10, no one would prefer doing a surgery for the patient. And I think that's how it should be taken care of in the current era, because there are so many litigations. If you're operating on a patient with a Vo2 max of less than 10%, I think you'll be in trouble. So what generally we see is we do a FEV1, we calculate the post-operative predictive FEV1, we do a DLCO, we calculate post-operative predicted DLCO. Even despite that, if it comes less, then we go for a Vo2 max. If even Vo2 max comes, then surgery is ruled out. So that's what, again, we are coming to the same point. If it's less than 16 mm, the complications are more. All deaths after lung resection in patients with Vo2 max, where the peak was less than 20. So exercise tests should be indicated in all patients undergoing surgery for lung cancer with the DLC or FEV1 of less than 80% of normal values. This is the recommendation by the STS. The grade of recommendation is B. I would not say 80%, but less than 60% of FEV1 and DLCO definitely we are considered doing a exercise testing. So since all that is a very high-tech exercise testing, we can actually do a 6-minute walk test. The distance walked in 6 to 12 minutes also gives us a fair idea, because basically you cannot do all those tests in all the patients, but one because of the cost constraints, the other because of the availability. So the more reproducible thing is to ask the patient to shuttle and walk. Those are the important ones. In fact, in the era of COVID, we have been more cautious. So what I do is I ask the patient to walk for 6 minutes, putting an app on his phone, ask him to walk for 6 minutes continuously and see what distance he has covered. So I see it myself. I ask him, I put an alarm, ask him to go for 6 minutes, come back after 6 minutes and see how much he has traveled. So if the minimum distance covered is 400 and if he is not having any desaturation after that, I would take him as a candidate for surgery, because we were not able to do PFTs and DLCOs for quite a bit, almost more than a year. We were not able to do it. So that is how we managed it. About, say, if the shuttle walk test is about 400 ml, or if there's a walk test about 360 meters, we would consider it to be safe enough to undergo a surgery. So this is about a staircase test. So the other is exercise oximetry. So you ask the patient to walk and you connect the saturation probe and you keep checking it continuously whether there is any fall in saturation and all that. So again, if it is again, we have to always correlate it with Vo2 Max. If the Vo2 Max is considering coming up to more than 20 ml, then we consider safe for a pneumonectomy. If it is less than 10 ml per kg, any kind of resection, even a wedge resection can have very high mortality. So that's all about exercise testing. The future trends are, we have to not only evaluate the exercise, we have to see what the daily life of the patient is, whether the preoperative daily physical activity is good. For example, if a patient comes to me with a malignant effusion, if the patient was doing well 1 week before, she was walking 1 kilometer, I would still consider operating her and doing a fluid assist, because I know her physical activity over the last 6 years or 7 years has been very good. It's just been the one episode of effusion which has caused so much of distress. So I would still consider her as a low risk for operative mortality. And the other thing is, now we have motion detectors which can be put on the patients, where the daily activities can be measured. The physical impairment due to COPD can also be assessed properly. This may give us an idea of whether the patients will have a post-operative problem. So the take-home slide for today would be this one. Although if you have not heard anything of the previous talk, you can just listen to this, because this gives us a fair idea of what we are doing. If the FE1 DLCO are more than 80%, don't worry about anything. Don't do anything. Even if the patient wants an pneumonectomy, do it. Nothing to worry about. If one of them is less than 80%, then you do exercise testing. You see what is the peak VO2. If it is available, that's the best thing. You do a Vo2 Max. Again, Vo2 Max, if it's more than 70%, no worries. Okay. If it's less than 75%, or if the value is less 10 to 20, then you consider doing the post-operative predictive FEV1. And if one of them is 30%, again, consider doing post-operative predictive Vo2 Max. If that's more than 30%, more than 10 ml, do a resection with a calculated extent, and also consider the patient and counsel the patient properly. Okay. And if it's less than 35%, then you don't consider any surgery for these patients, and you give SRRT or whatever the patient chooses. So few of the slides which I want to talk about is the surgical techniques which you want to do, whether you want to do a combined, a lobectomy or a segmentectomy. Based on that, you can, based on the patient's condition, you should operate it. For example, if there is a compromised lung condition, you consider doing a segmentectomy or a wedge dissection. You take a right balance between oncological radicality and functional reserve. For example, we did an 8-year-old last week. So the tumor was 2 centimeters. We were considering whether to do a lobectomy or a segmentectomy, but we did a segmentectomy because we know that the segmentectomy, the outcome will be better in terms of our immediate post-op, as well as once we have the whole lymph node basin taken up, the radicality of the this thing also procedure is also no less. So that is one of the things which we should consider. Always segmentectomy versus lobectomy, 2 centimeter, 3 centimeter lesion, better to do a segmentectomy and wait for the histopathology to consider any adjuvant therapy. If you're doing a good segmentectomy, the pulmonary functions are also better, especially in older patients. We consider doing a segmentectomy. So that is my talk for today. Thank you, CCI, for this wonderful opportunity. Thank you.
Thank you, Manjunath.
Okay, 5,
Thank
4,
you.
3, 2, 1. You are live.
Thank you very much, Dr. Himani Chhabra. Thank you, Dr. Manjunath, for giving a nice overview regarding thoracic surgery, regarding pre-anesthetic checkup, and repeatedly we have talked about the spirometry, CPET, and body box, and people have now good idea what is Vo2 Max and what is its significance. Before I proceed to the panel discussion, in which Keerat has helped me to create questions to make it more interesting. But we all know without audience, we are nobody. They are the gods when you are a speaker. If the audience is not there, then the speaker does not enjoy anything. So I go first to the chat box to welcome the audience, and we will address these questions what have been placed in the chat box. So I will start from Shri Ram Jahangirdar from Maharashtra, Nanded. Does incentive spirometry adds to the complication of BPF? Dr. Manjunath, will you answer this?
Yes, I'll take the question. Incentive spirometry will never lead to a complication or add to a BPF. BPF, again, the terminologies are very vaguely used because now we are more specifically using terms like peripheral layer leaks and central layer leaks, where we are like dividing again into alveolar-pleural leaks and bronchopleural leaks. So first thing we have to understand is when you're talking about leak from the airway, whether it's a central airway or a peripheral airway, and either of it, spirometry will never lead to that, never lead to a complication of BPF. If at all, if it helps, it helps. Otherwise, it doesn't. That's all.
Okay.
So
it's very a clear message. The spirometry does not affect the BPF or does not precipitate. Aruna Shanmugal, Tamil Nadu, Chennai. What is experience with Aristocrat scoring system to predict the post-operative pulmonary complications? Well, Dr. Himani, as an anesthetist, you will apply Aristocrat scoring system in your practice, and if yes, what it is?
Yes, sir. We do apply it routinely, as I already mentioned in my presentation also. So there are 7 predictors in that scoring. So with that, we get an idea of, how much is the probability of having pulmonary complications in the post-operative phase. It really helps.
Okay. So this basically tells you the prediction about the post-operative complications, correct? So now there is Amit Kiran Rath from Chhattisgarh, Raipur. Used to write duration of surgery before consultation. So what about Keerat? Will you like to comment on this? The duration of surgery before consultation.
Thank you, Amit Kiran Rath, for the question. So Amit from Chhattisgarh, Raipur. Amit writes that no one used to write duration of surgery before consultation. And Amit, that's a fact. Most surgeons, and at least at the point where we as pulmonologists receive the patient and receive the call for pulmonary reference for surgical clearance, the duration of surgery is never mentioned. At least in the system where I'm working, I have not seen any surgeon mention that. It is just an estimate that, okay, so and so procedure will take this much time. So we assume it will be a short procedure, it will be a long procedure. Okay, they are looking to use propofol, so short duration, short sedation they're using. Or for larger surgeries, we understand that this is a vascular surgery, it might take longer. But yes, I think I would like Dr. Himani's comment on this. Dr. Himani, do you wish the surgeon would write the duration of surgery? Do you think
yes, definitely for us also. But we do generally have an idea, because working in the OT, we do have an idea that this particular type of surgery is going to take this much time. But yes, there are sometimes, even we also want to know how much time the surgeon is going to take.
And it's a fact that with the longer duration surgeries,
yeah, definitely the risk
of
will
perioperative pulmonary complications.
Yes, yes, definitely it will increase.
So, Dr. Amit, when the surgeon walks in, he prays to God if he's religious, and if he doesn't believe into that, but he definitely prays on one or the other way that everything should go smooth in the OT. Whatever is time to be taken should not get precipitated, but nobody will ever commit about it. So, coming to Dr. Dwarika Nath Satpathy from Odisha, Bhubaneswar, what are the parameters to check in lungs before surgery? Radha Didi will like to answer this.
Yes, I'll take up that question. And Dr. Rakesh, I'm sure everybody present here, including Manjunath, Himani, Keerat and yourself will agree that we have to look at this question from 2 points of view. One is whether that surgery is a thoracic surgery and whether it is a non-thoracic surgery and a little away from the thoracic cavity, because you know that as you go away from the thoracic cavity, even in the abdomen, if it is a distantly situated surgery, then the risk of post-operative complications start falling down. Like it starts from thoracic, upper abdominal, lower abdominal, and then non-thoracic, non-abdominal surgeries or distant surgeries. So we have to look from that point of view and then take a decision what type of investigations are needed to look into predictability of perioperative complication, as well as a domain of Himani, where she would be looking into procedural complications which are non-surgical, especially the awareness about complications during anesthesia, which they must anticipate and manage beforehand before they're present. So first and foremost, when we talk about parameters to check in the lungs, the first and foremost is lung function test. However, I would also say that before even we go for lung function test, a thorough clinical examination is must, because literature says that the lung function tests which are altered and the surgery is away from the lungs, there may not be much perioperative complications. But if there are definitely positive findings on clinical examination, then there are issues which are increased in the perioperative phase and complications would be more. But my first thing is that spirometric evaluation is the first and foremost test which you should do, and you should be looking at FEV1, FVC, and the ratio, of course. And all of you have already highlighted the values that whenever the ratio is less than 70%, it's a definite risk for complications to occur. Now, depending upon the underlying pathology in the lungs, if it exists, then you are going to escalate the investigations which you want. So the next in line would be, which is easily available at many centers now, would be DLC. And we will be escalating. The parameters have already been told by Dr. Chawla, so I would not be stressing on the values now. But you should be looking at DLCO in patients, and you should interpret very cautiously if a patient is known case of COPD. After that comes the investigations like cardiopulmonary stress test, and if they are not available, then the test which Chawla and Manjunath has already stressed on are the shuttle tests, which are going into the incremental speed of walking and covering a distance, which would predict the risk of perioperative complications. I personally feel that everybody would like to have the best possible. And in my opinion, apart from doing what we all do and whatever may be available at higher centers, in my opinion, doing a ventilation perfusion scan would always be one of the best tests available or parameters available, because it lets you know the functional part of the lung. How much is that? And is it being sacrificed during thoracic surgery? Or if it is a non-thoracic surgery, still then, if V by Q is well maintained and there is no mismatch, then even for upper abdominal surgeries, there is no risk. But if there is already pre-existing ventilation perfusion mismatch, then I'm sure Himani would agree, and all my colleagues, that perioperative or even intraoperative complications may be more if there is V by Q mismatch. That's one. Second point I wanted to tell about, let me recollect about V by Q mismatch is, if I recollect, I would be telling you.
Okay, thank you. Radha Didi has enumerated very nicely what is the criteria, what has to be met. Now, Darshan, you are sitting idle. If PFT, see, we are talking about ventilation, perfusion mismatch, spirometry, DLCO, body box, CPET, shuttle walk, all kind of exercise testing. His question is Mahendra Singh Raghuvanshi from Madhya Pradesh, Vidisha. If PFT is not available, then what kind of tests we can perform for clinical assessment of pulmonary fitness? You put it that you are in a COVID situation. Nobody is doing spirometry, but cardiothoracic surgeon cannot sit idle. He has to earn his livelihood. So how you will proceed, Dr. Darshan?
So of course, sir, in COVID times, we have seen that we were not doing the PFTs and other lung function tests due to the issues already known to everyone. So in those times, we can assess the exercise capacity by going for the climb of stairs, flight of stairs, or we can see the walking distance of the patient. If he is able to walk by 400 meters at a reasonable good pace, like 3.5 miles per hour, or he can go for 0.4 miles at his own pace, and he can go up by 5 flight of stairs or 3 flight of stairs. So those things can give an assessment of the exercise capacity of the patient, and he will be a reasonably good candidate for going for a surgery, if in case we are not having a facility of PFT or other PFT investigation.
Can I add something to that, Dr. Rakesh?
Yes, ma'am.
When we went through the literature, and all of you must have read also, that doing cycling in a supine position in the bed, and if that patient does not develop hypoxia after doing it for 2 minutes, is a very good indicator or a predictor of the amount of exercise which the patient could be able to sustain. And when we look at the literature, we'll find that this was one of the tests recommended even to diagnose PCP pneumonias and look for hypoxia after exercise. A fall in, if I'm not wrong, 3% to 6% of O2 saturation after doing cycling in the bed for 2 to 3 minutes was mentioned. I do not remember the figures, but I remember I have read that for diagnosis of even PCP, like there are shadows, and if you want to diagnose it earlier or comment upon it. So I think doing cycling in a supine position in the bed is also a very good exercise or an indicator whether oxygen saturation falls, and then you can predict about the perioperative or post-operative complications, or even fitness for that matter.
Thank you, ma'am. Keerat wants to check.
Yes, may I add that for a cycle ergometer in supine position in bed, if the patient is not able to attain a heart rate of 99 or above that, then the patient is supposed to be unfit for surgery. This is sort of a very, very crude method. If you look, it's like looking at the cardiac capacity, a very crude method, like similar to CPET, but very crude version of it.
Keerat, what you mentioned is about the cardiac capacity and attaining heart rate. But when we look at if it induces hypoxia, this amount of exercise, then it's a good indicator of lung function also.
Thank you.
I don't know whether Himani wants to add something to that.
Himani, we are coming to Himani. Manjunath has already told in his lecture that he was practicing what Dr. Darshan, what Dr. Radha, and what Keerat has told to do these surgeries, and he was satisfied with these exercise tests. Again, Mahendra Singh Raghuvanshi from Madhya Pradesh, Vidisha, to Dr. Himani. Is there any different criteria for giving pulmonary fitness under spinal anesthesia or general anesthesia? Is there any other different criteria? If yes, then what is the criteria? No, then it is all right.
So for definitely the risk of pulmonary complications is less in spinal anesthesia as compared to general anesthesia, and it is advisable to use regional anesthesia whenever possible. Unnecessarily, you should not interfere with the airways and the pulmonary thing. But definitely for all the spinal cases also, we should keep in mind that all the spinal cases can need to be converted to general anesthesia during the surgery, because spinal can get failed, or it can, the surgery duration has increased, so the effect is over. So we may need to convert it to general anesthesia. So we should be, get the patient evaluated the same for both the things. What I think. Because
Ajay Lanjewar, flat number 201, Indranil Heights, Maharashtra, Nagpur. Do you recommend clamping ICD while asking patients undergo post-operative physiotherapy? As we see, the column rises significantly during inspiration, making underwater seal lost. Yes, Dr. Manjunath. What is your comment on the post-operative phase? Yes. Because during inspiration, this usually happens, and the fluid is going into the lung, and it is moving so frequently, so level is fluctuating. I know CTVS surgeons are using the Euro bags rather than the ICD bags, which is used by the pulmonologist. What is your comment about it?
Sir, I wouldn't clamp the chest tube in any post-operative scenarios, especially after a lung surgery, because the moment we clamp the lung, there can be, if there's a small peripheral layer leak, the lung will collapse. And to get back the lung, to expand the lung, and again, we have to do, the patient has to put a lot of effort, or we have to do a bronchoscopy to expand the lung. So in any post-operative scenario, I would request, like everyone to not clamp the lung unless it's like really, really needed. No, don't clamp the chest.
Very nice.
Physiotherapy, no need at all.
It's very clear. We don't have to clamp the ICD during physiotherapy post-operative surgery. Subramanyam Sharma, Iskupalli from Maharashtra, Nanded. Role of echocardiography in assessment of surgical clearance. My dear, we are coming in discussion. You will realize ASA classification 1 and 2. We don't even need an X-ray chest or routine investigations or ECG and X-ray. Keerat is going to talk about it. If the patient is specifically having cardiac problems, yes, echo should be done. It will be a routine. Otherwise, ECG does a good job. So there are factors which will determine whether echo should be done or not. There is a medical legal question. Already we have answered 2 questions of Dr. Mahendra Singh. In our discussion, you will listen about the medical legal part. So I think I have done my duty towards my God, which is an audience. Before we were prepared to discuss it, I will put in Darshan. Tell me now what I am talking is importance of utility of routine investigations. I know ASA 3, 4, 5, ASA 1 and ASA 2, where 60% of surgeries are done. What is the utility of routine investigations? Yes, Dr. Darshan.
Sir, so first of all, a thorough history and clinical examination are the cornerstone of any evaluation. Because our goal is to improve the outcome, we have to decrease the morbidity associated with the post-pulmonary complications. So our basic goal is to identify any pre-existing health problem. We have to assess any unsuspected medical condition like diabetes or maybe hypertension or maybe anything else. Then we have to have a baseline for later comparisons. Then, of course, we want to predict a pre or a post-operative complications. And then, of course, as we have already spoken about, that we have to save ourselves from the legal liabilities also. So this is also a byproduct of doing a pre-op evaluation, sir. But of course, literature says that many of the tests are inappropriately done. So the reason which came out to be, it was a protection from the legal liabilities. So the X-rays like PFT or an echocardiogram or an ABG or a CPET test. So there should be selectively done, sir. The patient profile depends largely on the patient profile at what kind of patient we are tackling with, because many of the times we are tackling patients who are absolutely normal. So in those patients, we just need to have a thorough history and physical examination and a basic routine test. So in those kind of patients, we can avoid all these investigations. However, for X-rays, I must say, because in our Indian setup, we receive a different profile of patients. So because many times patients tend to hide their history also. So I will go against with the current literature that which says X-ray is also not required many times, because we as chest physicians should have a baseline chest X-ray for sure, sir. So that is my take on that.
No, your take is correct. We are with you. In Indian scenario, Indian system, chest X-ray 9% showed abnormal changes in, and because we are a tuberculosis predominant country, so you are able to rule out the active infection, which may be dormant and patient is not aware of. He has come for the PAC. But to my surprise, at the beginning of my lecture, I said, Indian Society of Anesthesiologists should pick up this to make guidelines for PAC. And they can request Krishna Bhai, involve CCI, and in the banner of CCI, do these guidelines and take a credit of Indian guidelines for making an PAC. But to chip in, there are 400% increase in the number of medical malpractices cases in the Supreme Court over the last few years. Even though a large majority of these cases are related to surgery, if it's not known how many times routine preoperative testing contributed to the defense of anesthesiologists and surgeons involved. So several peers perform these tests as a blanket rule, as Darshan has said, with notions like more the investigation, better is the safety. So what is the opinion of the House about this, that we should go or we should be selective in few class of patients like ASA1 and ASA2, and if they are 3, 4, 5, I agree. So what is the opinion of the House? I will like to have discussion from Himani, Manjunath, Keerat, ma'am, Radha. So you can give your opinions.
I think no one has ever sued a doctor for getting a chest X-ray done. It's the cheapest test. Although I do say, let me give you a very recent example. A patient was shifted to the OT and then I was called for a pulmonary clearance. And this was a patient who was posted for amputation, below knee amputation, and otherwise was not having any comorbidity, but counts were raised. Now, should I insist on a chest X-ray at this point of time?
Yes.
So these are some real life things. Should I ask for the patient to be shifted out of the OT? What if the counts were normal? Now, even the international places for some countries, they say even blood counts need not be done. So we can't follow those guidelines in an Indian scenario. We do need what we need to make sure that the patient is safe, because if something goes wrong, over here, doctors are not just sued, they're also beaten. So we have to make sure that the doctors are safe, and legally we are safe, and we are not doing the patient any harm by investigating. A lot of times patients are not aware, or they're ignoring their symptoms. They may be unwell, but they're saying that, oh, it was just the weather. Very commonly they'll say, fever ho jata hai, kyunki thakavat se ho jata hai. It's very common. Seasonal fever ho jata hai ji. So we have to investigate and rule out.
And so it gives us confidence on both the sides, patient as well as the doctor. So both are means like we're dealing with a normal healthy patients, it gives us confidence.
We have to save the patient as well as us.
Absolutely.
In countries like India, because where the health system is not that, the patients are not going for routine health checkups. So sometimes PAC is, our first encounter with the patient, first time the patient has come for any kind of health checkup. So it's very important that we should have a baseline, at least a baseline, investigations for, comparing with anything which happens later on.
All of us agree that baseline investigations like routine lab, X-ray, ECG should be there in every case who comes in our system for PAC, correct?
And secondly,
I'm correct about it?
It also depends upon the type of surgery the patient is undergoing. If it is a simple cataract surgery or a very superficial skin surgery, we may skip these things. But if it is
allow me to add, Himani, with my personal experience, what we have seen. Earlier, when patients used to be referred from ophthalm OPD, we were reluctant to see the patient. क्योंकि हमको लगता था कि इसमें रोल ही नहीं है हमारा. But as we kept on looking at the patients, we have realized that cataract is a very, very important surgery, though it may be minor or superficial. It's very valued surgery. And all those patients who are smokers, who have COPD, who have cough, it already predicts the outcome of the surgery because patients are advised not to have cough. It raises their intraocular pressure, and it's not advisable to have repeated bouts of cough. Another important thing we have to remember that all surgeries, almost all, are done in a lying down position. And there are patients who are asthmatic, COPDs, ILDs, who have cough as soon as they lie down. Either because they have not been diagnosed earlier for COPD and treated for mucus clearance, whatever may be the reason. And fortunately, I have the anesthetists are well aware of this and they keep on sending the patients to us. Now we have got a mindset that yes, all patients must undergo even pulmonary clearance because it's not a clearance. We are adding something, some valued input for better outcome. Like if a cataract patient comes and I tell him you are not getting operated for 15 days at least till a second PFT is done and I'm happy that you don't have anything. The patient cries. He says, "Aap hamare doctor nahi ho." But then I have to talk to the ophthalmic surgeon and tell him that agar aapko outcome chahiye, if you want to avoid this, this is the thing. And they are very happy in postponing their cataract for 15 days. I don't know what is the experience of others in this regard.
Himani, I will like to chip in. You be honest, as Keerat has said, patient is on the table. You are called to give a pulmonary clearance. Is it true for the patient or it is true to save? I'm not saying Himani. It is like anesthetist available in the country or the surgeons available in the country since you are representing anesthesia. So is it justified? Patient on the table. This is one scenario. Another scenario of every day. You must be coming. You have been called for the pulmonary clearance. You have seen the patient has got a COPD. Patient is on nebulization. As a pulmonologist, you told the patient should go for spirometry. X-ray chest has got COPD. Surgeon and anesthetist team, whatever are the interests, surgeon says, "Yaar, push the patient, theek thaak hai, sab koi tension nahi hai, take the patient to OT." By the time you come and see patient is already shifted to the OT, they are not bothered about spirometry. Anesthetist is bothered for whatever are the things. Tell me honestly, what is the justification of the convenience of the surgeon and anesthetist by doing all this or calling the patient is on the table that please come and give the fitness? I know it is a routine in all hospitals across the country. We are hypocrites. We talk different, we behave different. But the message should be very, very clear that why society should blame us. Why we should say we overdo the things to save us from litigation. What about the patient's pocket? What about inside that I want to get maximum surgeries done in a day because today is my day to get the surgeries done. So I should finish all them in a lot. So can you comment on this, Dr. Manjunath and Dr. Himani? I know it's a wrong trap, but I know time was finishing. Let me talk and the audience should listen the truth happening in OTs.
Sir, I can add first. I agree to you that it is not ethical as well as not a nice thing to call the pulmonologist or a cardiologist on table or while shifting to the OT for a clearance, which is absolutely wrong. It is you can say a poorly managed system. Sometimes I should not be lying that we also end up in some scenarios where we are compromised in calling up in a late night or something. But on table calling a physician for a review is not a great idea. I mean, I would rather cancel the patient and send him back and do it on a later date, unless we are totally pressed or there is an emergency for which the patient can die. Otherwise, there is no explanation for that kind of scenarios. That's my take on it.
Yes, Himani.
I agree, sir. It has never happened with me as such that I have taken the patient and on table, I have to call for clearance. If it is anyways needed, I send it in the preoperative phase only. So, or at least in the preoperative room, because we re-evaluate the patient before taking in the OT. If we find anything new or something which has been missed out, we can make the decision at that time. And if it is not being done and the patient is directly shifted to OT without even being, reviewing in the pre-op room, then that practice is really not right.
Thank you, Himani. Please stick to the guns. You are growing, yes, you will grow. I will talk
and
to you.
And as I said, we have to, save the patient and save us also.
See, we are the kings of this sea. So
no, actually, we should make a protocol that
you will grow. Protocols are set aside, rules are made to break. Everything is happening, will happen, and you will also grow with all this. I think I come to Keerat, and Keerat, I make you in charge to stop the discussion. Wherever you will feel ki sir, ab time ho gaya, we can stop. There are 2 messages in the chat box. Must give me time to finish that 2 audiences, right? Do you think every patient should get through the PFT for surgical clearance, Keerat?
Not at all, sir. Not at all. PFT cannot be a standard prescription for every patient that we as pulmonologists receive for pulmonary clearance. Unless we have a reason to believe that this patient could have obstructive disease, obstructive airway disease. And I would like to quote here the American College of Physicians. They are recommending PFT preoperatively only in a certain set of cases. And I do agree with that to a good extent. Not every patient should undergo PFTs unnecessarily. If you still want to, maybe you could do just a PEFR if you want, but not PFTs. And the set of patients who must undergo PFTs are those patients who have any symptoms suggesting airway disorder. Let's say anyone who has dyspnea on exertion or unexplained dyspnea, anyone who's a smoker, anyone who is planned for a major surgery. And when we talk about a major surgery, we mean cardiac, thoracic, or upper abdominal surgery, or anyone who has, say, a head and neck surgery or a distant or an ortho surgery, but has an uncharacterized lung disease. So these are the patients who should undergo PFT to characterize that disease. Anyone who's a diagnosed case of obstructive airway disease, they should undergo PFT to grade and score the disease and to plan optimization before they are taken up for surgery. And the rule of the thumb or the hard rule is that any patient undergoing resection, lung resection, must undergo PFT testing. However, I'd like to add here that PFT testing, it tends to overestimate the lung function loss post-surgery.
Wonderful. Thank you, Keerat. Darshan, how to avoid post-operative complications? What cares you will take so that your patient should go safe home? You are a pulmonologist, thoracic surgeon will do the job and he hands over the patient to you. What do you feel, how you will avoid so patient is safe home?
So, sir, it is said well begun is half done. So, a good pre-op assessment with, and it depends largely on the type of surgery, site of surgery we are dealing with. So, means if you are talking about a general case or a thoracic case, sir?
See, we are talking about thoracic program. So, how you will avoid the complications so that everything goes comfortable?
So, of course, for a thoracic case, we have to go for the PFTs and advanced the investigations like maybe a DLC or a CPET. So they will largely predict that whatever the values which are coming on those investigations, they will largely tell us that the patient's fate after the surgery. Like if a patient is having a good DLC or a good pre-operative FEV1, he is good to go with a pneumonectomy or a lobectomy. So, but in case the patient is having a equivocal type of or in middle of values which are in middle, say 60 to 80% of the FEV1 or a DLCO, which is less than 60%. So of course, these patients will be prone for complications. Of course, we can't go for a pneumonectomy in these kind of patients. We will have to, if we at all want to do, we can go for a lobectomy. And secondly, sir, apart from these investigations, we have to see if the patient, we have to give some prophylactic measures. Like if patient is a smoker, we have to advise him to cease smoking for at least a period of 3 to 4 weeks. Ideally, it should be 8 weeks, sir. And then, sir, if there is any active infection, we have to first control the infection and we can delay the surgery for that time. Then, of course, the anesthetist, spirometry, the CPAP, the breathing exercises, the pulmonary rehab programs. So all these measures, they have to be instituted before surgery also and after surgery also. And post-operatively, some measures like preventing the thromboembolism, like you have to minimize the aspiration risk by keeping patient in upright position. We have to tackle the early mobilization of the patient. We have to tackle the post-operative pain management. So these all are the strategies which will be able to, means the patient will be recuperating in a better way if we take care of all these things. So this is...
Thank you, Darshan, for enlightening. I am picking and choosing. I am proud to say, apart from interventional pulmonology, what world is practicing we are doing. I am the pioneer in sleep medicine. In 1996, Colin Sullivan, I got a training for sleep. In North India, I started the home studies. I have all kind of sleep labs. Now coming to the practical situation, Radha Munja ma'am, Keerat ma'am, Himani, patient of obstructive sleep apnea, patient of obesity. The pulmonologist is called in to give a clearance. He gives you how to manage this patient. He advises a polysomnography. Tell us honestly, how many times a pulmonologist advises PSG and anesthetist and the treating surgeon or a physician agrees, yes, this patient should go for PSG. Don't tell me we do it. Tell me the example, how many times the rest of the fraternity, let it be cardiologist or a physician or a surgeon or an anesthetist, agreed कि नहीं सर पहले PSG कर लो, अपनी तसल्ली कर लो और उसके बाद patient को हम लेंगे for surgery. Please.
Can I come in, Rakesh?
Yes.
That was a wonderful question. And I'm sure many of my colleagues won't agree, but probably that is an advantage of working in a teaching institute. And we had a good chunk of patients who were undergoing bariatric surgery. So you can imagine the level of obesity or morbidly obese patients. And we do polysomnography. When I got it, say around 7 years ago, I got it. It remained underutilized for some time, but we now do for every obese patient referred. Fortunately, we have less number of patients who are being referred, and I can cater to that. And what we do is that 8 days pre-op, we put them on whichever support they need, either BiPAP or CPAP. And my anesthetist says that she's very happy with this. Like we don't give clearance for at least 8 to 10 days. We do titration, we put on CPAP. We have to do a lot of exercise, like patient every night comes, then he stays with us, goes back and all that. But all in all, with the cases which has received support, my anesthetists have said that during anesthesia as well as post-op management and complications have been less. This is my experience. So I would always advocate that these patients, at least those patients who are not only obese, but have any other symptoms of sleep disorder, breathing or obstructive sleep apnea, should undergo polysomnography, because there are lots of other complications associated. It's not only respiratory, but there is cardiac overload, some overload on the heart, arrhythmias, there are many things. And then anesthetists would agree that they fall into category of difficult intubation, no doubt about all those factors who contribute to OSA and are associated with obesity. I think others should take on. This was my experience.
Keerat, your young experience.
Sir, I would like to say that when we're dealing with obese patients per se, they are not always the case of OSA. So if I get an obese patient, I will not always subject them to a PSG unless I have a stop bank questionnaire which I keep handy. But so I will not subject every patient who's obese to a polysomnography unless they give the symptoms that they're snoring or they have daytime sleepiness, etc. Right? But for me, a more important test would be an ABG, to see that if there's any evidence of obesity hypoventilation, if the daytime PCO2 is maybe more than 45. But I have not come across any patient who I have not found an abnormal ABG in obese patients. I would not recommend PSG unless I find symptoms for OSA. And this is my take on it.
In fact, one of our papers are on way of publication, so perhaps we might have more evidence. It's already on way.
Keerat, my question was, you are satisfied, you have diagnosed a case, he's a sleep apnea. He is not fitting into the category where PSG should be done. Did you advise and the team agreed you go ahead with the PSG?
Yeah, so for me, we don't have any problem with compliance.
Very nice. What about Darshan? What is your experience in Lucknow, KGMC?
As Dr. Keerat rightly said that we have to screen the patients with the stop bank questionnaire, sir. And then accordingly, we will subject the patient to PSG. And the evidence also says that obesity as such is not a risk factor for post-operative pulmonary complications. And moderate to severe OSA may lead to, in some cases, the PPC may be high. But otherwise, obesity as such is not seen as a major risk factor for PPC, sir.
Very nice. What about Himani? How you manage such patients post-operatively and per-operatively?
In PAC only, like Keerat said, that we follow that stop bank criteria, because all the patients cannot be labeled as OSA. So if, he matches with that criteria, then definitely we want him, if, BiPAP or CPAP initiation is required before surgery, and definitely we can ask for the ABG also to, know for his baseline CO2, and definitely be sent to the pulmonology people. And whatever they say, of course, we'll wait and we try to follow it. And our main motive is like we want the patient to be optimized. If he is a known OSA patient, that a definitive therapy should be started preoperatively if it is going to modify the post-operative course.
Correct. So post-operative use of BiPAP, post-extubation, using nebulization. So
it will be easier for us to.
Right. I am coming to, because there are indications coming to wrap up the program. Rajat Saxena, Delhi. Again to Himani, is ETCO2 monitoring is mandatory for all patients under general anesthesia?
So that is one of the minimum mandatory guidelines by ASA. So there are 5 minimum mandatory guidelines like BP, ECG, temperature, ETCO2 and oximetry. So ideally it should be, used in all the patients, but I know in a lot of peripheral centers and a lot of even in the government centers, you don't have ETCO2 in all the OTs. So the limitation is there, but definitely it should be used.
So now coming to the final question, very, very important talk of neglected place of pulmonary medicine, pulmonary rehabilitation program, especially in the post-operative period. So I will start, because all pulmonologists talk about pulmonary rehabilitation. If you get back to the hospital, see the departments, the pulmonary rehabilitation program is totally a neglected program. You tell first to motivate the patients, and patients will go to physiotherapy department. So they will learn the techniques and disappear from the scene. Without physiotherapy, without physiotherapists, they will try to do and save some money, but not sticking to the rehabilitation program. So starting from Manjunath, I will like everybody to comment about pulmonary rehabilitation, how they are practicing and how it should be. That is very, very important, especially when you are in a post-operative phase. So before we conclude. Yes, Manju.
Sir, the first thing is, at the first visit of the patient to my OPD, I advise them intensive spirometry, deep breathing exercises, yoga, and at least I ask them to walk for about 2 to 3 kilometers per day. For all patients who are undergoing a major lung resection, This is the bare minimum they have to do. And I check the spirometric effort at the first time and see what is the volume. And I ask them to repeat, come to me after a week at least to see what is the improvement been after good practice. That is the first step I feel which is more important, because the moment people understand okay, this is important, they start doing it more effectively. And then you have to explain the patient that once the surgery is done, this is what is going to bring you out of the ICU early. This is what is going to send you home early. I think that message should be conveyed to the patient properly. And then whatever the physiotherapist adds on, that's a bonus actually.
Yes. Himani, regarding rehabilitation, Darshan, please chip in quickly.
I would like to add that rehabilitation is not only exercise, but also psychosocial support, nutrition, then self-education. These all components should be there in a rehab program. And of course, exercise is only a part of it. And we should also look after the other aspects also, sir.
How is your rehabilitation program in King George?
So we are yet to establish a good rehab center, sir. But
and you know, you are the oldest department of respiratory medicine, you know, oldest department of respiratory medicine in the country, 100 years.
Maybe by the end of this year, we will be able to establish a good rehab center, sir.
So this is what I wanted to touch our youngsters. Yes, Keerat.
Sir, I want to add now that Dr. Darshan just said that nutrition also, you know, psychosocial help also. So one thing that came to my mind is that cachexia or a malnutrition patient, that is definitely at increased risk of perioperative pulmonary complication, maybe not an obese patient. So nutrition is definitely very important.
Nutrition is a very, very important part of it, and anemia is very, very common in Indian population. Right, before I close, so
I wanted to add only one sentence to all this, Dr. Rakesh. Can I?
Yes.
Yes. What Manjunath said and everybody said was very true. And when you train these patients pre-operatively, it becomes easy to give them breathing exercises post-operatively, because patient is in pain. And that's actually not the best time for patient to take up and do it at an optimal level. So if he has done those exercises earlier, he has understood everything. And with pain, a little limitation, but he would definitely make efforts.
So here we have a dedicated physiotherapist for thoracic surgery patients who starts in the preoperative phase. You know, we try to increase the effort tolerance in the preoperative phase, and in the postoperative phase, from day one of the surgery, patient is out of the bed walking, and we give complete good control of analgesia by putting epidurals and PCA pumps. So I have not seen, you know, developing those kind of complications routinely in post-op period, because we have aggressive, regime followed here. We have dedicated people for that.
Wonderful. Yes, Keerat.
Yes, I want to add that in routine practice also, I really like to push for pulmonary rehabilitation. And I like to, one thing that I find is that keeps patients hooked on is when you ask them to document their progress. You ask them that you walk. I tell them that in 20 minutes you have to walk, and in what you have to note how many rounds of a park or how many rounds you're doing in that much time. And you must increase it by 1 round every other day or after every 2 days, depending on the patient status. And I ask them to document it. One thing. And second thing, I always try to take this opportunity to advocate tobacco cessation and smoking cessation whenever I get that.
Wonderful. The last now, we are said to be a resource limited country. We are very rich with money. There is no dearth. If you ask me in India today, scenario, no dearth. We used to be a TB specialist, grown to be respiratory medicine, pulmonary medicine, critical care, sleep and interventional pulmonology. But our medical colleges, our institutions still have only a basic test of spirometry. I think the government should see to it the respiratory departments. They are so important and backbone of any surgery to be equipped with body box, CPAT. These should be the government-aided programs rather than you are asking for the CPAT and the DLCO and your body box and having all these tests. Why our hospital and why our patients should not have? This is what I have the opinion I will like to have the opinion of the House before I say thank you. Yes, Radha ma'am.
Rakesh, that is a very, very important statement and invitation that you have put on this forum. I don't want to create any controversy, but whatever we wish for and we might get, I find the most important hurdle are the NMC norms, because these are the things which are followed like a Bible or a Gita in any medical college, be it government, be it private. And the requirements of pulmonary medicine are so low, including the staff and the equipments, that I think it would be very few institutes would go beyond and have more staff, more equipments, and provide facilities for even undergraduates and postgraduates. It really takes a lot of efforts and grit to develop a department and have all these modalities, which I will never term as high end. These are all basic requirements of a good respiratory medicine department. It's not only for learning of the students, but it's for delivering the services to the patient. And we all know that respiratory diseases and morbidity, they are on high rise, and a time would come that you are already going to surpass the cardiac morbidities and disorders. I truly feel that there should be some consensus and some action towards this. And we see that the guidelines on which the medical colleges are functioning or get their equipments or other facilities should definitely be revised. And as you know, we are already trying for that, but it has yet not been achieved. So on this platform also, I would again appeal to CCI as one of the opinion forming society, as well as they can start a movement. And if we can achieve this, it would go down in history, basically. That's my opinion.
Ma'am, the unfortunate thing is it is made by doctors, made for doctors, accepted by doctors. So we know heart of heart our limitations and the system's limitations. So we don't get into this. It's a Pandora box. Any other opinion, any things before we close? Yes, Keerat.
Very well said, Radha ma'am. I really agree with what you've said. And I think that is the reason we support people like Radha ma'am and Dr. Rakesh sir to be policy makers in our country. So this is the faith that we place in you. And whenever you would take something like this forward, CCI has the power, it has the capacity. And I know by the end, sir is saying that the Indian Anesthesia Society should take out the guidelines. I know Dr. Krishna sir will give the order before midnight that you make, the guidelines. CCI should come out with the guidelines for pulmonary assessment, for giving clearance to the anesthesia people. And I know this for a fact that Dr. Krishna, he'll give out this order before midnight. So this is how CCI is working.
I think that will be the achievement of our webinar, that CCI formulating Indian Society of Anesthesiologists guidelines for PAC to write a history. I am sure about it. So, Keerat, we can stop now.
Thank you, sir. Thank you so much.
Thank you very much.
And we are very, very thankful to the whole CCI team, Dr. Krishna.
Thank you all, my co-panelists, Dr. Himani.
Thank you, sir.
Thank you so much, sir.
Radha, Darshan Bajaj. Hope I justified the whole scenario. Thank you.
It was a wonderful.
Sir, you were great.
It was a pleasure being
Thank you,
here
Dr.
with all of the
Rakesh,
veterans
Himani,
and
Keerat, Manjunath, and
Thank you, ma'am.
Thank you, everyone.
Thank you. Thank you.
and Dr. Bajaj too, Darshan Bajaj. Thank you. It was wonderful interacting.
Thank you.
Thank
Thank you.
We are now over.
a wonderful
Yeah,
experience
no,
with veterans like you and Dr. Rakesh sir here, sir.
Thank
And
you.
the superstars like Dr. Himani, Dr. Keerat, and Dr. Manjunath. Also, I will take this opportunity to give thanks to Dr. Krishna and Dr. Atri for inviting me for this academic event.
Good.
Thanks
Very
a lot.
good. So at the end of the day, thanks to Krishna Bhai, Vijay. Thank you, Vijay.
Vijay.
Thank you, boss. Thank you
Dr.
so much.
Atri.
It was a really, wonderful. People were stuck to their seats for past 2 hours. You people made a very, very great job. Really proud of the entire team. Thank
And
you all.
sir took all the questions from the audience also.
Thank you.
All questions from the audience were answered.
Yes. Yes. They are the gods. Thank you.
Dr. Rakesh.
Surprisingly, there were less questions from the audience. I think we are off air round right now.
We are off air. I think we covered so much already. And the thing about CCI, we had 900.
Yes, and importantly, Keerat, there may be very few, the audience which has logged in from them. Perhaps there may not have been many referrals for pulmonary clearance.
They were around 1,000 logins, ma'am.
I know. They were around 1,000. नहीं, मैं बोल रही हूँ कि probably pulmonary reference ज़्यादा नहीं होता होगा कुछ parts में, इसीलिए ज़्यादा queries भी नहीं है. ऐसा भी हो सकता है. It can be either way. Or they are getting lots of references and they are already well versed with everything, and so they don't want to raise a question. Either way.
For myself, that today's going through the material really exposed the gap between international guidelines and what we need in India. I would not say what we follow, but what we need in India.
Keerat, you won't believe it is almost more than 6 years that I have already made a presentation on pre-op assessment and pulmonary morbidity 1. And you would be surprised that was the time when I was looking into those ophthalmic cataract cases. And you won't believe one cataract came out with a CA lung. He was asymptomatic. We all know they are bound to be asymptomatic.
We can even say that in India, since the screening for the health,
yes,
is so poor, at least this should be an opportunity. We take this as an opportunity.
And if like when you go for a PFT, when you go for a spirometry, workshops and all, and you keep on saying कि भाई heart के लिए आप ECG करते हो, temperature के लिए आप thermometer use करते हो, so to look at lung health, PFT should be done and so on. You keep on saying, but that is not being advocated. Not done.
I think if we have more clear guidelines and they ultimately will end up becoming part of the textbook that we follow in India, over the years, it should get better. The scenario should get better.
Nice. So keep me in also when you kickstart the guidelines. Thank you.
Thank you so much, sir.
Thank you all.
Thank you very much.
Last but not least, Dr. For the backbone, Cipla and Puneet, Vinod, Amit team, thank you so much. And lovely having you, your support anytime with the CCI. Thank you. Thank you all. Thank you, Dr. Himani, Dr. Radha ma'am.
Thank you everybody. मजा आ गया और बहुत पढ़ना पड़ा. मुझे तो लग रहा था कि राकेश वाइवा लेके ही छोड़ेंगे हमारा.
No, that's a wonderful conclusion at the end. We are going to come with, thank you, Dr. Keerat, for bringing that important statement. We are going to come with a wonderful paper, which consists of maybe around, 6-7 papers is good enough to give a directional guidelines.
Guidelines, right?
Yes. And
I'll look into my own data and see whether I can publish it, say within a month or two in one of the index journal. ढूंढना पड़ेगा सर, डेटा बहुत गुम हो जाता है.
My opinion is that will be a consensus statement.
Yes.
Don't stop at a statement. Involve, chip in good anesthesiologist, give responsibility with CCI core people, involve Rakesh Chawla as a pulmonologist, right? To make the Indian guidelines, make it proper the way I am inviting you to thoracoscopy guidelines in the country. Soon you will be there with me. You will have a first-hand experience how they are made. Follow it and make it and take a credit because it is on NCCP ICS platform. Make it on CCI platform, ASA, like ASA, Indian Society of Anesthesiologists for PAC guidelines. It should go as a granth. It will be a document which should be published by any leading Indian journal. You get it? It's a marathon task, but it should be done.
No, we can start.
Fantastic conclusion, Baj. Yes.
Now I'll start bugging you for that, sir. And
please, I think
we are there.
Even the last week webinar, the pre-conference workshop preparation, we made a 3-paper guidelines.
Wonderful.
So, we have done it already, the rough one. So Shivani and then Sonam is working on to build up the next level. And then we'll share it to Dr. Amita, Dr. Rajadhar to modify it. And then we're going to publish. Probably we're not going to take too much time. Probably less than one month, we'll be publishing it. And I wish the similar response from this team as well. And please, Dr. Himani, please help them.
Very nice.
Yeah.
Thank you.
Thank you.
Thank you. Bye. Good night.
Thank you, Vijay.
Thank you.
Good night, all.
Good night.